Hello and welcome to Stanford Cares monthly community health talk series. My name is Dr. Jisan Hong, and I will be your moderator. I am pleased to bring you the series of talks co-sponsored by Stanford Care, Stanford Health Library, and the Vincent V.C. Wu Memorial Foundation. I'm very pleased to welcome Dr. Joy Wu, who will speak on prevention and treatment of osteoporosis in Asian Americans. Bone loss is common with aging, and over 50% of women and 25% of men over the age of 50 will sustain a fragility fracture due to osteoporosis. The risks of fracture may vary between Asian and non Asian populations, and also between different Asian subgroups. Dr. Joy Wu will discuss risk factors for bone loss and the role of diet, exercise, and medications in optimizing bone health. Joy Wu, MD PhD, is Chief of the Division of Endocrinology and Vice Chair of Basic and Translational Science in the Department of Medicine at Stanford. Dr. Wu is an internationally recognized leader in bone health and the treatment of osteoporosis. She directs a basic and translational research program that focuses on skeletal development, stem cell therapies for bone, and breast cancer bone metastases. She has served on clinical guideline committees on bone health for the Endocrine Society, the American Society of Clinical Oncology, and the American Society for Transplantation and Cellular Therapy. Dr. Wu earned her MD and PhD degrees at Duke University, followed by clinical training in endocrinology at Harvard Medical School before joining the Stanford faculty. She was a recipient of the NIH Director's New Innovator Award, and her research has been funded by the National Institutes of Health, the Mary Kay Foundation, and the Department of Defense. Dr. Wu is a former member of the board of directors of the Endocrine Society and is currently a member of the Council of the American Society for Bone and Mineral Research. Please join me in welcoming Dr. Wu.
Thank you, Dr. Hong, for that invitation. It's really a pleasure to be here. And I want to thank Stanford Care and the Stanford Health Library for this opportunity to discuss one of my favorite topics, which is the prevention and treatment of osteoporosis and how we can optimize our bone health. So first, by way of disclosure, I am a member of the Scientific Advisory Board for Crinetics Pharmaceuticals. This evening, I'm hoping to cover several topics of interest to this audience. We'll go over a definition of osteoporosis. We'll discuss who should be thinking about their bone health and tested and screened for it. We'll discuss ways, both lifestyle and medication, that we can use to improve our bone strength and prevent fractures. And then we'll talk about, finally, the medical options for treatment of osteoporosis and some common concerns about safety. So let me start with the take-home messages that I hope you'll carry away from this evening's talk. The first is that fractures due to osteoporosis are indeed serious, but many are preventable. Fracture risk depends on many factors, which we'll review. Lifestyle changes can slow, but usually not reverse bone loss. And when used properly, osteoporosis medications are very safe and very effective. All right, so to get started, let's discuss the definition of osteoporosis. The word literally means porous bone, and it refers to a decrease in bone mass that leads to increased fragility and an increased risk or likelihood of fracture. And this is just a figure from the International Osteoporosis Foundation showing an artistic rendering of what your bone might look like under the microscope. On the left is the bone of a young, healthy adult. You can see nice, thick plates and connections between the bone. And then on the right is bone from an older adult, and you can see the bone is thinner, there's more empty space, and you could imagine that this bone might be easier to fracture. So osteoporosis is a very common disease. Half of all women and at least a quarter of all men will experience a fracture due to osteoporosis sometime in their lifetime. And just to put this in perspective with other common chronic disorders, within the US, there are approximately 34 million adults who have low bone mass. This is very similar in number to those who have high blood pressure, and just somewhat lower than those who have high cholesterol. What's often underappreciated is how devastating osteoporosis fractures can be. So each year in the US, there are approximately 300,000 hip fractures, similar to the number of cases of newly diagnosed invasive breast cancer, maybe half of the number of heart attacks or myocardial infarctions that happen every year. The most sort of shocking thing about hip fractures that occur in the US is that the mortality within 1 year is very high. Almost 1 in 4 individuals will die within a year of having a hip fracture, not necessarily because of the fracture itself, but because of some of the complications that happen afterwards. And you can see that this 1 year mortality is much higher than you would expect after an MI, and even higher than that of someone diagnosed with cancer. As another way to think about it, the risk for women of being diagnosed with breast cancer is 1 in 8 or 12% over a lifetime. And compare that to a 50% chance of experience of fracture due to osteoporosis. For men, the risk is more similar to a lifetime risk of being diagnosed with prostate cancer, as having a fracture, roughly about 20%. So this is a striking photograph I took a number of years ago at one of the bone and mineral conferences that I attend. It's a cast of 5,500 fractures meant to represent the number of fractures that occur each day in the US. That's 2 million fractures per year. And it may be a little hard to see, but in the back there is a person. So that gives you a little bit sense of the scale. It's truly an impressive sight to see in person. So 2 million fractures occur due to osteoporosis every year. This makes osteoporosis a pretty significant public health challenge. At least 10 million Americans, 80% of whom are women, are diagnosed with osteoporosis. We mentioned that there are 2 million fractures a year. And these cost numbers are already out of date, but the direct costs per year probably exceed 20, if not $30 billion. What kinds of fractures can be attributed to osteoporosis? Among the most common are spine or vertebral fractures, about a quarter of them. It's also very common for women who fall, maybe slipping on the ice or the snow, falling on an extended wrist, can experience wrist fractures, about 19%. We've mentioned the hip fractures that are so deadly, those are about 14%. And the remaining osteoporosis fractures are in the pelvis or other bones. And the way that we describe a fracture related to osteoporosis is what we call a low trauma or fragility fracture, meaning a fracture that occurred falling from standing height. So you tripped over the curb, you slipped on the ice, you were seated and maybe fell out of the chair, and a fracture that results from that is considered low trauma. Of course, if you were in a motor vehicle accident or if you fell from a height on the roof or something, that of course can increase your risk of fractures, and we would not consider those necessarily osteoporosis. But somebody who slips on the ice and fractures their wrist, that is indeed a fragility fracture and can be a sign that bone strength is not very high. The kinds of fractures that people can experience due to osteoporosis change over age. So these are just 4 different kinds of fractures, and these numbers across the x-axis are age in decades. And so what you can see is that wrist fractures are most common in younger women, so women in their 50s and early 60s. That's partly because as women slip and fall, it takes some reflex time and coordination to sort of extend that arm. And so reaction time is probably a little faster in younger women. And so they're able to extend their wrists. But unfortunately, in the process of doing that, they can sustain fractures. In contrast, hip fractures really do not become prevalent until women are much older, in their 70s or 80s. And perhaps that's because they're not so able to break their fall. And when they do trip, they just sort of fall onto their hips. Other fragility fractures like spine fractures or arm and shoulder fractures sort of are equally distributed among women of different ages. In my osteoporosis clinic, I do have a special interest in caring for women who are patients and survivors of breast cancer. So I just want to make the point that osteoporosis is quite common among many cancer survivors. For example, in women with breast or ovarian cancer, there are a number of factors that contribute to bone loss and fracture risk. Chemotherapy can be tough on bones. Chemotherapy in women who are still premenopausal can cause ovarian failure and lead to premature menopause. For cancers like breast cancer that are positive for estrogen and progesterone receptors, endocrine therapy to lower the actions of estrogen can be very helpful in preventing cancer recurrence, but at the cost of causing weakening bones. And then some cancers are quite commonly treated with radiation therapy, which also has effects on bone. If there are men listening on this webinar, you are not exempt. And in medicine, we spend quite a bit of time talking about gender disparities, usually referring to how women are underdiagnosed and undertreated for diagnoses and diseases. But in the case of osteoporosis, it's actually the men who are not well diagnosed and treated. So a third of hip fractures occur in men in the US. That's about 75,000 a year. What's particularly striking is that men are actually more likely to die, almost twofold more likely to die after hip fracture. That's perhaps related to the fact that men are older when they have hip fractures, but also men are 50% less likely to receive the appropriate treatment. So for all those men who are listening, do be aware to advocate for yourselves and your bone health. All right, this of course is a lecture for Stanford Care. So Asian Americans are a diverse and beautiful population, the fastest growing racial and ethnic group within the United States. This is data from the Pew Research Center showing a really remarkable climb in numbers. And of course, it's always challenging to discuss Asian Americans in any kind of uniform manner because it's of course a very diverse group of individuals representing many different countries of origin who may have been in the US for a long time, for a very brief time. This again is data from the Pew Research Centers showing the populations within the US and their countries of origin, and you can see again quite diverse. Within the osteoporosis field, we are starting to appreciate the impacts of those diverse countries of origin, but I would say we have a lot of work to do. So this is from an editorial I wrote a few years ago about the importance of understanding the impact of race and ethnicity on fracture risk. And so I want to make a few points. Here is for a given person of the same age, height, and weight, but of varying race and ethnic backgrounds, you can see that the risk for a white woman in the US is higher than that of a woman who is Asian. And these are using fracture risk calculators we have that were developed by the World Health Organization. So in the US, if you're broadly defined as Asian, which of course encompasses many, many different groups, your risk of fracture would be considered lower than that of a white woman who has the same bone mineral density. However, if you look at these are country-specific calculations, again, using the same numbers, but varying the countries of origin. And in red, I've highlighted several countries from Asia. And you can see that there are widely varying fracture rates, starting from a low rate among women in the Philippines to very high rates among women from Taiwan and Uzbekistan. So it raises the question of, what are we actually capturing in this group of US Asians? What if you were an immigrant from the Philippines? That seems like it should be different from somebody who has come from Singapore. Does the length of time that you've been in the country matter? All of these are important but unanswered questions. All right, so now let's talk about who should be tested or screened for osteoporosis and how can we do that? So there are a number of risk factors that are associated with more rapid bone loss. Of course, age is one of them. We are all losing bone as we age. Peak bone mass actually occurs in your late 20s and early 30s. After that, there's a steady decline. In women, there's a period of faster decline around the time of menopause in the 5 or 10 years around the menopausal transition. If you've had a previous fracture, so the case I alluded to earlier, a woman who slipped on the ice, fractured her wrist, even if her bone density scan turns out to be in the osteopenia or normal range, the fact that she's had a fracture in and of itself predicts higher risk of future fractures. Glucocorticoid therapy and other medications, these are including medications that we call steroids. They can be wonderful for reducing inflammation and treating diseases of inflammatory different conditions, but they can cause accelerated bone loss. Family history matters, particularly if you've had a parent who has had a hip fracture. So I see many patients in my clinic, and they'll tell me in the course of conversation that their 85, 90-year-old mother, grandmother, aunt fractured a hip, went into the nursing home, and then, within a year had died. That's very in keeping with what we know about the natural history of this. But what people are not often aware of is that again, might be preventable and raises your own risk if you are the child of an adult who had a hip fracture. In medicine, we often tell individuals that being overweight is a risk for various health conditions. But in the case of osteoporosis, it's the opposite, that there seems to be an increased fracture risk with low body weight. Other things that raise your risk of fracture include use of tobacco and smoking, excessive alcohol intake, more than 2 drinks a day for women or 3 drinks per day for men, inflammatory diseases like rheumatoid arthritis. And then finally, secondary osteoporosis refers to a large number of conditions, diseases, and medications that can cause bone loss. Why do we need to identify risk factors? Because it turns out that if you look at all the hip fractures, 50% of them happen in only 16% of the population. And these are often, again, patients who've had a prior fracture or who have other risk factors. And the goal here is to try to identify those individuals who are at higher risk so that we can target therapies to increase bone mass and lower the risk of fracture. So the gold standard here in the US for screening for fracture risk is to assess a bone density, and it's done by something called a DEXA scan. So who should have a bone density test? Well, lots of professional organizations have come up with consensus guidelines, and it's generally agreed upon that women who are age 65 and older should have a screening bone density scan. It's generally agreed upon that men should also have screening bone density scans, but the exact age is a little bit debatable. So some societies say age 70, some say 75. Again, men fracture at an older age than women. If you're younger than 65, over the age of 50, and have significant risk factors, including the ones that we reviewed on the previous slide, then those individuals might also be good candidates for a bone density test. Anyone who's had a fragility fracture or low trauma fracture after the age of 50. And then finally, if you're taking a medication or diagnosed with other conditions like rheumatoid arthritis that are known to be associated with bone loss, it's important to speak with your doctor about whether you should have a bone density test. So the most common way to assess bone density is something called a DEXA scan. This is our scanner here at Stanford Hospital, along with one of our wonderful radiology technicians. It's a non-invasive, non-painful test. So you simply lie down on this bed. This arm rotates around. Most typically, we measure bone density at 2 sites. One is the spine and the hip. For many years, Stanford only measured the left hip, but we now measure both the left and right. Sometimes patients have had a hip replacement. Sometimes there are reasons why they can't measure one. So it's nice to have both. And what this shows you in blue is these are aged across the lifespan, starting from age 20 to 100. And the blue bars represent the average bone density across the age. So you can see again, peak bone mass in your late 20s, early 30s, and then there's a steady decline. In women, during the period right around menopause, there's a time of faster decline, and then it levels out a little bit more. This is especially pronounced in the spine, where there's more surface area of bone, so we see a bigger change during menopause. If this were a bone density scan for a man, it would just sort of steadily decline. Men don't really have the same analogous transition as menopause. And then shown in green is the area of normal bone density. These are defined by the World Health Organization using something called T-scores, which refer to the standard deviation of a measured bone density compared to that of a young adult around the age of 30, matched for gender and race. And so you can see, as a young adult, your bone density is in the normal range. As it gets lower and lower, it gets into more high-risk categories. So I'd also like to make the point that fracture risk really depends not only on bone mineral density, but also on age. So this is using a calculator called FRAX from the World Health Organization. It allows us to enter an individual's age, gender, weight, height, race, and ethnicity, and calculates the estimated probability over the next 10 years that this individual might experience a hip fracture. And so, for various reasons, the professional societies have agreed that when this 10-year risk exceeds 10%, we should think about treating with a medication. Bone mineral density, again, is measured as T-score, so standard deviation compared to young adult men or women matched for race and gender. And so the World Health Organization defines osteoporosis using bone density as a T-score of minus 2.5. And so remember, I said that bone density screening begins at age 65. And so a 65-year-old woman who is right at the cusp of osteoporosis would just meet that recommendation for medication treatment at 3%. What happens in younger women is that because age can be, young age can be protective, we find that younger women can often have a bone mineral density as low as minus 2.7, minus 2.8 before they reach that threshold. But the converse is also true. So these curves are plotted by age at 5-year intervals from age 55 to 80. And what you can see that is an 80-year-old woman, even at a T-score of minus 1.2, is already at the threshold of having a 10-year fracture risk where we would recommend treatment. So often I'll see older adults in my clinic who maybe fell and had a fracture of their wrist or were diagnosed with a spine fracture. They were very appropriately referred for a bone density scan. And then the bone density scan returned a report that said either normal bone density or osteopenia. And then they're told not to worry about it. But in fact, if you've had, if you're older and your bone density is not even, in the minus 2.5 range, it's still possible that the risk could be high enough to merit treatment. I also want to point out that the number of risk factors that an individual has also influences their risk of having a fracture. So again, this is the same woman, age 65, even height and weight, and checking off more and more numbers of risk factors. And you can see that as the number increases, so does the risk of fracture. Finally, if somebody on a bone density scan has a very low bone mineral density score, so a T-score of minus 2.6, minus 3, that is very predictive of high fracture risk. However, the converse is not necessarily true. And that's because by definition, a T-score of minus 2.5 is lower than about 2.5, is lower than about 95, 97% of the population. And so most of the population, just by the way that T-scores are defined, will actually fall into osteopenia or even normal bone density ranges. So this is a figure showing that the number of fractures at the hip that occur in individuals with varying T-scores at their total hip. And then in the dotted line is the distribution of bone density across the population. And this is to make the point that half of all fractures occur in people who have a bone density measurement in osteopenia or higher range. So if you have a bone density scan that comes back with osteopenia, it does not necessarily mean that you're in the clear and not at risk for fractures. So it's important to factor in other things like age and other risk factors to calculate your own personalized risk. All right. Once we've identified that you have a risk of fracture or you're just wondering how you can be proactive in improving your bone health, there are a number of things that we can all do. So these are the Surgeon General's recommendations for optimizing bone health from a lifestyle perspective. So you can get adequate calcium and vitamin D, and we'll talk about this on the next few slides. Exercise is wonderful for many benefits, including strengthening your bones. You can reduce your risk of falls. So this means things like wearing shoes that are, not likely to trip. Making sure that in your house, if you have, throw rugs, that they're tacked down securely on the floor. Maybe having a night light at night so that when you go to the bathroom, you don't accidentally trip in the dark. It's important to maintain a healthy weight, and again, not too low because that does raise your risk of fracture. Um, don't smoke or cut back. If you do, limit alcohol use. And finally, if you're taking medications or you have other conditions that might be associated with bone loss, do speak to your doctor about your risk. All right. So let's talk about how much calcium we need. The goal is generally around 1,000 to 1,200 milligrams per day. You can get this through dietary sources. And the easiest way to remember that is dairy products are a wonderful source of calcium. One serving of dairy, a cup of milk, a cup of yogurt, an ounce of cheese is roughly 300 milligrams. So if someone is getting 2 to 3 servings of dairy products a day, they're likely very close to 1,000 milligrams. And that's because there are other foods like broccoli and other dark green vegetables who have calcium as well. But it is true that many adults on a Western diet don't have 3 servings of dairy a day. Most people tell me that they have at most maybe 1 or 2. If that's the case, then that's okay. You can take calcium supplements to reach a total of about 1,000 milligrams. Calcium supplements come in different dosage amounts. It's important to remember that you can't absorb more than about 500 milligrams at a time. So unfortunately, you can't just take 1,000 milligram calcium tablet and be done. You need to split that. Assuming you have no intake in your diet, you would need to split your supplements into 2 500 milligram tablets. If you take acid blocking medications, so these are H2 blockers like ranitidine or proton pump inhibitors, then you should be taking a form of calcium called calcium citrate because it's not dependent on acid. But otherwise, if you don't take acid blocking medications, it's totally fine to take calcium carbonate. And in fact, this is the same ingredient that's in Tums and over the counter uh, generic Tums substitutes, which I've actually found can be cheaper than if you're trying to buy calcium supplements. And calcium supplements come in different forms. One very popular form among many of my patients is a gummy chewable calcium that's available over the counter at the pharmacy. At the same time as taking calcium, you also need enough vitamin D. Vitamin D is what helps your intestine to absorb the calcium. And so the goal here is roughly in the range of 800 to 1,000 international units a day of vitamin D. Vitamin D is available over the counter as vitamin D3, which is also the form that you would produce in the skin in response to sun exposure. This is an animal-based version. You may also see vitamin D2. That is a plant-based vitamin D supplement. Both of them seem to work pretty well. And again, for most people, you need in the range of about 1,000 international units a day. The other very, very important lifestyle uh, activity that you can partake in to increase your bone health is, of course, exercise. So the recommendations are 150 minutes of moderate or 75 minutes of vigorous activity a week. Comes with all sorts of benefits beyond the bones. For bones specifically, it's really helpful to have strength training 2 to 3 times a week. This can be with free weights, it can be with resistance, rubber bands, but something to challenge your strength 2 or 3 times a week. Other things that are helpful are working on balance and flexibility. So if you like yoga or Pilates, the Bone Health and Osteoporosis Foundation has very helpful recommendations here on their website. I also recommend taking a look at this other website, milioguide.com. It's prepared by a physical therapist who really specializes in exercises for osteoporosis. All right. So now we've talked about the things that you can do lifestyle wise to optimize your bone health, but sometimes that's not enough. So sometimes you have either a history of fracture or you have a low bone mineral density on a DEXA scan, and we really need to think about other interventions like medication. So, how do we decide who needs to be treated with a medication? So again, we talked about how women over the age of 65, men over the age of 70 or so, younger adults who have risk factors or a history of fracture should have a screening bone density, also known as a DEXA test. For those who have osteoporosis, a T-score less than minus 2.5, or who've had a history of a hip or spine fracture, then by definition, these individuals have osteoporosis and they should be treated. If your bone density score comes out in the osteopenia range, so that's a T-score between -1 and -2.5, then we can use the calculator that I mentioned earlier called FRAX to calculate your 10-year fracture risk. And I like to use the 10-year fracture risk for hip fracture. And if it's greater than 3%, we also recommend treatment. 3% doesn't sound like a very large number, but again, I hope I've convinced you that hip fractures are indeed devastating. So we want to have a low threshold for treatment. So I won't get into too much detail about osteoporosis medications, but in general, the amount of bone that we have is a balance between how much bone is being broken down and how much bone is being made. So quite simply, the way that we can impact the amount of bone we have is we have medications that can block bone breakdown. These are called anti-resorptive medications. And we have medications that can promote bone formation, also called anabolic agents. By far, the most prescriptions are written for anti-resorptives, so medications on this side of the column. We tend to reserve bone building or anabolic medications for more serious fracture risk or osteoporosis. This is a busy chart of the different kinds of medications that we have available for osteoporosis. On the top in pink are the anti-resorptives. So these are the ones that stop the breakdown of bone, and again, the most commonly used for osteoporosis. They come in a few forms. There are oral medications called oral bisphosphonates. You might be familiar with them from magazine ads or television. They include alendronate, which is marketed as Fosamax, risedronate, marketed as Actonel. These are safe and effective. The most common side effect, and it's not that common, is gastroesophageal reflux, so GI irritation. And these medications do have a contraindication for individuals who have kidney dysfunction. If taking the pill form causes GI upset, we can switch to an intravenous medication called zoledronic acid or Reclast. It's quite convenient because it's given once a year as an infusion. And again, is limited in individuals who have chronic kidney disease. The second class of medications is called denosumab. It's a monoclonal antibody against a protein called rank ligand. It's given as a shot in the clinic twice a year, and it has some nice characteristics. It does cause a very significant increase in bone density. It can be used in people who have less than fully functioning kidneys. It's important to remember, however, that if you're on denosumab marketed as Prolia, that this medication can't be stopped abruptly. It needs to be followed by one of these classes up here. Below in green are the bone building medications, or the anabolic agents. We have three, teriparatide and abaloparatide, which are daily self-injections. And then the most recent medication is called romosozumab or Evenity. This is given in the clinic once a month as an injection. Because these are injectable medications and because patients often are not enthusiastic about injections, these are not commonly first line except in individuals who have very severe osteoporosis. And so again, most of the medications are up here. And I do want to make the point that for those individuals who have cancer, most of the safety data has been in these anti-resorptives. So these are the preferred options for individuals who have a history of cancer. The sequence matters. So I mentioned that the anabolic agents are usually reserved for serious osteoporosis or a history of significant fractures. So again, we have three. They must be followed by an anti-resorptive. Otherwise, you'll spend 1 to 2 years of a lot of work giving injections or receiving injections, building up bone density. If you stop and don't switch to an anti-resorptive, all of that bone can disappear quite rapidly. Your options after the anabolic agents are either the bisphosphonates or denosumab. And then again, to make the point that if you're on denosumab, that also cannot be stopped abruptly. So after however many years of treatment, then you would want to switch to the bisphosphonate class. And finally, I want to take a few minutes to discuss something that many patients come to me with concerns about, which is, are osteoporosis medications safe? In my clinic, I really do nothing except care for individuals who have osteoporosis. So over the last 20 years, I think I've literally heard it all. So it's quite common for individuals to come in with a number of concerns. Of course, many people prefer not to take medication and would prefer natural or lifestyle remedies. There are people who are very sensitive to medications and their side effects. There are some concerns in the public about the safety of these medications. And of course, if you've known somebody personally, a family member or a friend who had an unpleasant side effect, that will also influence your willingness to take medication. So in particular with osteoporosis medications, there are rare, very rare side effects that can affect the oral cavity called osteonecrosis of the jaw. This was reported now almost 20 years ago, and in response, there was quite a bit of concern, and many patients and their physicians sort of stopped taking these medications to the point that the numbers of fractures which had been falling over time in the country were starting to rise again. And so in 2011, the American Dental Association actually came out with a statement, and it says that, keep in mind that discontinuing osteoporosis treatment, especially with bisphosphonates, will have a negative impact on the treatment of low bone mass. In other words, that will raise your risk of fractures. So perhaps more visually illustrated here, this is a chart showing the numbers of spine, wrist, and hip fractures in gray among 100,000 patient years. So for instance, 10,000 people treated for 10 years or followed for 10 years, you can see there would be thousands of spine, wrist fractures and a number of hip fractures. In contrast, for these same number of individuals, if they were treated appropriately with osteoporosis medication, you can see that there's a big decrease in the number of fractures. The rare side effects that many people are concerned about are osteonecrosis of the jaw and atypical fracture. And this graph makes the point that they are indeed rare. And in fact, it's a little hard to see, but they're plotted for numbers of years of treatment. So 5 years versus 10. And really, they don't become detectable until patients have been treated for more than 8 to 10 years. And so this has led to the current guidelines, which say that for most individuals at moderate risk of fracture, we can treat for 5 years and then give a drug holiday. And this allows us to very safely use these medications. Another way to think about it is now over 10,000 patient years, appropriate use of medications, this is the number of fractures that could be prevented. And if you contrast that to over 5 years, the number of atypical fractures that might be expected is very, very small. So again, in the appropriate patients, the benefits of 5 years of treatment for osteoporosis, I hope I've convinced you, really far outweighs the risk. Now, returning to the impact of race and ethnicity, this was a study published a few years ago by Kaiser in Southern California. And it did raise the awareness that, of course, we've known that fracture risk differs between women who are white versus women who are Asian, Black, or Hispanic, all of whom have a lower fracture risk for a given bone mineral density. But this also raised the important point that Asian women in particular may be at slightly higher risk for atypical femur fractures, so one of those rare complications. So it is important to be aware that women of Asian descent do seem to have a different risk-benefit profile than other ethnic groups. And so this was just one study, but it was pretty well done with a large number of people. So I have been, in my practice, particularly cautious when I treat women who are Asian, maybe being a little bit more proactive about building drug holidays into their treatment regimen so that we can avoid rare complications. It's also important to point out that these are very rare complications that are time dependent. So again, we really don't see an increase until after 5 to 8 or even 8 years of treatment. And again, now the standard of care would be to think of a holiday well before that time point. The reassuring thing also is that within very quickly after stopping the medication on a drug holiday, that risk seems to fall. So within 1 year off of a medication, that risk is almost back at baseline. And so with that, I want to summarize again take-home messages, which are, I hope I've made some progress in convincing you that fractures due to osteoporosis are indeed a serious public health issue, but often are preventable. That your fracture risk does depend on a number of factors. The most important are age and whether you've had previous uh, fractures and bone density, but other things like your height and weight, family history, other medications, alcohol use, smoking all have an impact. Lifestyle changes are very important. They can definitely slow down the rate of bone loss. They're not often enough to completely reverse somebody who has osteoporosis, but they still remain very important. And when used properly, osteoporosis medications are very safe and effective. And finally, I'd just like to conclude with some thoughts about what we can do as a community to work towards even greater understanding of osteoporosis in Asian Americans. So to start, we need much, much more data, and we need to disaggregate. I won't be the first to say this about Asian Americans, that we really need to disaggregate data by the group of origin, country of origin. We need more information and studies so that we can, of course, maximize the benefit and minimize the risk with treatment and medications. Asian groups in the US include many immigrants, and so the impact of the country of origin and the time spent in the US, I think, are critically important to understand. And then finally, our current calculators don't have any way to assess the impact of risk in individuals who are multiracial. So I think that's another important area that bears studying. We need culturally relevant education. So for instance, many of my Asian patients are not taking in a lot of dairy. So we need to be thinking about other sources of calcium like soy products and other, plant-based milks and other things. And then, as always, we need to work on increasing the diversity of the physician workforce, because there's really great evidence that concordance between physicians and patients can help with trust, language barriers, and all sorts of things. So with that, I will pause, and I see there are a number of questions. So thank you all for listening, and I'll start to take questions.
All right. I'm going to group them into different themes that I've kind of got from pre-questions that were submitted before the lecture, as well as those that have come in through the Q&A section. So a lot of interest in other supplements other than calcium and vitamin D. What are your thoughts on things like boron, vitamin K, magnesium?
Right. Wonderful question. So, um, in my practice, I limit my recommendations to things that have been studied and shown to be effective in large scale randomized clinical trials. So, in terms of supplements, we have the best data for calcium and vitamin D. So, those are my two recommendations. I get a lot of people who are interested in vitamin K in my clinic, and there are indeed preclinical studies which seem promising. And there's sort of biological reasons to think that vitamin K could be important in the bone. But until we have solid randomized clinical trial evidence proving that they're beneficial, I don't make a formal recommendation. For other supplements, you mentioned boron, magnesium. I think, again, the jury is still out. And so I'll stick with calcium and vitamin D.
And then there was a clarification question. So you talked about splitting the calcium supplements. Does that mean splitting morning and night, or two supplements at a time, which are 500 milligrams each?
So you need to split the doses morning and night. So you can't absorb more than 500 milligrams at a time. So it could be breakfast and dinner.
Perfect. Lots of interest in strength training. So how much weight? And then lots of questions about weighted vests.
Okay, great. So strength training, when I first started my clinical training and then my practice, I was very ginger in my recommendations, right? Of course, my patient population includes a lot of older adults, and some are in their 70s and 80s. So I was very circumspect in my recommendations, and I would say things like, "Oh, try lifting cans of soup," and then this really remarkable study was published in Australia a number of years ago, where they subjected women around the age of 65 to, at the time I was working with one of our clinical fellows who was very interested in weightlifting. He was a bodybuilder himself. And he said, quote, "This is real weightlifting." So I asked him to define, what do you mean by real weightlifting? And he says, when you look at the study design, they determine what they call the 1 rep maximum. So for a given exercise, maybe a chest press or uh, some kind of weightlifting maneuver, you find the maximum weight that you can lift one time. So I would joke with my fellow that his 1 rep max was about 300 pounds and mine was probably 20. But it doesn't matter. You start at 80% of that, and then that was how they built up. And that really made me appreciate that at any age we should be striving to push ourselves, right? So again, for me it could be 20 pounds, for him it could be 300, but it doesn't matter. What matters is that you are just approaching where it's a little bit maybe uncomfortable, of course, being careful with form and that kind of thing. But I think there is no point at which we don't benefit from striving to push for better. And I think you really see that in athletes, right? Athletes who are
Mhm.
working on improving their race times or their strength or whatever parameter, they have to push themselves. And so I think that's really changed my approach. So again, there are some weights I can only lift 5 pounds. That's my maximum, but at least that is my, significant effort. So I think, you would think it would be straightforward to prescribe exercise, and that has not been, because it is, of course, very hard to do exercise trials. But I think there are a lot of good recommendations out there.
And you said about 2 to 3 times a week, correct?
Yes, ideally, 2 or 3 um, episodes of strength training, 30 minutes at a time.
Okay. Next question. You talked about a drug holiday for Fosamax, and you had recommended ideally a little before the 5 year mark. Is there like 3 year, 4 year, or it really is dependent on the patient?
Yeah, so the sort of professional organizations, for instance, the American Society of Bone and Mineral Research, to which I belong, they've issued their task force report says that for women at low or moderate risk of fracture, they can consider a drug holiday, um, after 5 years on oral medications and after 3 years on intravenous infusions. Um, Again, those are low, maybe moderate risk. Somebody who's at high risk of fracture, the need for a drug holiday may or may not apply, because you always have to balance the benefit of the medication itself against the risk. And for people who are very high fracture risk, the benefit is overwhelming,
Mm.
lowering that risk. Now, for patients in my clinic who are of Asian descent, because of that study that I showed, that suggests that women may be at slightly higher risk for atypical fractures, I do sometimes tailor it. I do offer a drug holiday a little bit earlier, maybe 3 years of oral, again, 2 to 3 years of IV. It's very much on a patient case by case basis, but it's something I'm thinking about. Um, it's not something that we have a whole lot of data to guide us on yet, so it's one of the areas we need to study, but it is a factor to consider.
And as a rheumatologist, I often will order DEXA scans in patients who I prescribe steroids for, and the report always says, please consider repeating in 2 to 3 years.
Right.
Is there 2, 3? It doesn't really matter. And then when you go on a drug holiday, does that interval change?
Right. So, in general, bone density scans for most people don't need to be done more frequently than 2 years. I always tell patients it's, waiting for change in bone is like watching grass grow. It changes very slowly. So, if you started a medication, if you stopped a medication, 2 years for both. There are very rare circumstances where somebody's at risk for very rapid bone loss, and often then you can do one in 1 year. But 2 years is generally what I recommend. So in somebody who has sort of enough fracture risk or bone loss that we are thinking about screening, then I think every 2 years is pretty reasonable. Some, younger adults or somebody who really has a very normal bone density, you could argue for stretching it out a little bit longer.
Um, Next question. Uh, Several questions about the role of hormone replacement therapy, like estrogen, for the treatment, or how that affects bone health.
Yeah, absolutely. That's a great question. So, there's no question that hormone replacement therapy is beneficial for bones. The reason that women lose bone around menopause is because of the loss of estrogen. And so, hormone replacement, if you were to only focus on bone, would be beneficial. Unfortunately, what we now know is that hormone replacement is complex and also carries risks, particularly of increased breast cancer. And then also, it did not have the protective effects against cardiovascular disease that I think many people assumed for decades, right? We have long known that men have more cardiovascular disease than women until women go through menopause. It was very natural to assume that that was because of the loss of hormone levels circulating. But in large trials, that didn't prove to be beneficial um, to give hormone replacement. Now, since the WHI trial was published in the early 2000s, a lot of studies have been done. And, things in medicine often are like a pendulum. They sway one way and then back a little bit. So the pendulum for hormone replacement therapy has gone from, everybody was on it and then nobody was on it. And now, it's become clear that some people do benefit. So um, in women who have just gone through menopause, hormone replacement therapy in the first year or two, maybe three, can be very beneficial for reducing things like hot flashes, which can be incredibly troubling to some people. So I think that's now a very well accepted indication. Specifically for bone health, although hormone replacement, of course, is beneficial, I don't recommend it because it carries other risks. And we have medications that are so much more specifically targeted to bone and, frankly, more effective. So,
That's great. Other than steroids or glucocorticoids, are there other medications that can increase risk for osteoporosis? And I think somebody specifically asked about GLP-1.
right. So, there are other medications that can be associated with bone loss. I think anti-seizure medications, perhaps because they cause metabolism of vitamin D levels. Patients with HIV who are on the antiretroviral therapies, they can cause bone loss. Some anti-immuno or some immunosuppressing medications after transplant, also like cyclosporin, uh, also have been associated. GLP-1, it's a fascinating question. That they're certainly the talk of the town right now because they are associated with weight loss in the range that we've never seen before medically, right? And as newer and newer drugs come out in this space, there are, people are talking about 15, 20, 25% weight loss. That's never been possible with medication, only with bariatric surgery. We know that people who lose a significant amount of weight also lose bone and have increased fracture risk. We know this from bariatric surgery or people who've lost a lot of weight. So it is an area of concern. I haven't seen anything published yet, but these studies are, so new that they're probably still ongoing. So I think there's going to be a lot of interest in, when people lose dramatic amounts of weight, they lose bone and they lose muscle, and so there is a significant amount of concern that we don't want to increase fracture risk or cause sarcopenia is the formal name for losing muscle. So there will be a lot of interest focused on how we might prevent that.
Mm. To what extent does Prolia decrease the immune system?
Right. So when Prolia first was introduced, a lot of these studies are based on decades of preclinical studies in animal models, and there were some hints in particularly rodent models that rank ligand, which is the target of Prolia, might be involved in the immune system. So there was some concern that there might cause some immune function, and in the early trials there have been some reports of maybe increased skin infections. It hasn't really panned out, to my knowledge, that Prolia significantly impairs the immune system. And Dr. Hong, as a rheumatologist, you might be better poised
Yeah,
to
I
answer that
don't I
question,
don't
but
see
it's
so
not
much.
something I've
Yeah,
heard too much about.
and we will often combine it with other immune suppressive
Exactly.
medications, so it's something that we're not too concerned about. Um, a good question. So, bone density scans, I believe, scan one side of your body. um, do the scan results of the left hip, for instance, reflect accurately what's going on in the right hip?
That's a great question. So now at Stanford, we scan the spine and both hips. That's
Oh,
a relatively recent, maybe within the last 5 years. Our radiologists now scan both sides and report both sides. The funny thing about bone density scans is we use the worst T score, so the lowest T score at any site, and it predicts fracture everywhere. So it's a very common question that people will come in and say, "Well, I have a low bone density in the spine, so therefore I must be only at risk for fracture in the spine." And I completely understand that, but it's actually not true. So having a low bone density at any site predicts fracture anywhere. And we can't really point to where, because I think it depends a little bit on the circumstance of that fracture, right? So if you fell on your arm, well, then it's your arm that's likely to fracture. If you, some people experience spine fractures while they're lifting something heavy. Other people, I've had patients sort of, involved in accidents that fractured the upper arm. So it's not always easy to predict how somebody will fall or what bone will be subjected to those traumatic forces. So it's a great question, but a low bone density score at any site predicts fractures sort of generally.
another question that came up was osteoporosis and joint pain. And I get this a lot as a rheumatologist. They tell me I must have osteoporosis because I have pain in my joints. Does osteoporosis typically cause pain apart from if you have a fracture?
Right. So osteoporosis is clinically silent, right? So we generally can't feel our bone density until, of course, you have a fracture, and then it's terribly painful. So um, you know better than me, but joints are their own entity. And so if you have pain in the joint, it's usually not related to osteoporosis. Of course, there are inflammatory joint diseases that, because of the inflammation, can cause bone loss. But the pain is not due to osteoporosis. It's usually a joint related process.
Yeah. And I always say osteoarthritis and osteoporosis sound kind of similar.
Me
But yeah,
too.
it's
Me
usually
too.
the osteoarthritis
Right.
or rheumatoid arthritis that would cause the pain. Um, More questions. There was a question about PPI usage and bone loss. Is that a common medication that also can increase osteoporosis?
Yeah, so proton pump inhibitors, PPIs, they're used for treatment of GI upset and by lowering acid levels. They've been reported to cause a modest decline in bone density across a large number of people. And so this is one of those scenarios where, again, you have to look at the big picture, right? If you have terrible reflex disease and the PPI is the only thing that works for you, I wouldn't want to not take it just so that your bone doesn't experience a negative side effect. And we have very effective ways to prevent bone loss. If lifestyle is not enough, we can think about medications. So I think, again, big picture and trying to sort of optimize benefits across the body.
Um, Questions about PTH and denosumab increasing bone density. Any difference in bone quality and bone strength?
Right. So that's a great question. The different medications can have somewhat different effects on the bone mineral density, and they all are pretty effective at lowering fracture risk. They can't get FDA approval without that. And it's actually very interesting. Uh, Fosamax, alendronate, doesn't increase bone mineral density to the same degree that either PTH or denosumab do. Yet it's a very effective medication for reducing fractures in osteoporosis. And so the answer, I think, is partly because bone density is not 100% of your fracture risk. I already discussed how half of all fractures happen in people with osteopenia, non-osteoporosis. So I think bone density is the best assessment that we have, but it's not perfect. It's not a crystal ball. And so there are other things that go into what we would call bone quality. And so bone strength, material properties, and there's a lot of interest in the research labs on trying to understand different ways to assess your fracture risk in terms of bone quality. It's just that right now, bone density is the most understood, most widely available, and really the best predictive tool that we have.
Are there new types of drugs that are coming in the pipeline?
That's a great question. So, 20 years ago is an incredibly exciting time to be training in the field because Prolia had just been, denosumab had really just been developed, and they were working on what would eventually become romosozumab, which is Evenity. And that. So we've had a number of medications released over the last 10 or 15 years. At the moment, there's not a whole lot of new medications in development for the pipeline. What is, I think very interesting and exciting are other approaches. So, for instance, our laboratory and others are thinking about stem cell approaches. So we're trying to grow stem cells in the lab and turn them into bone forming cells. So I think that's an area that's, still early, but stay tuned.
Very exciting. That's like the epitome of precision medicine right there.
Exactly.
All right. I think that is all the time we have for today. There are many great questions, and thank you so much for this amazing talk, Dr. Wu. And the like Nina had shared in the chat, the recording of the talk will be posted on Stanford Care's YouTube in about a week. So please subscribe so you get notified and get notified of all the other future care talks.
Wonderful. Thank you, Dr. Hong, for moderating. That was
Yeah,
quite a challenge. Lots of questions, but always a pleasure.
yeah. All right, everyone. Have a good night.
Good night.